Well, good morning, everyone. I see that people are pouring in to our virtual breakfast this morning. Welcome to the Boca Chambers October membership breakfast. It's actually the last one of our fiscal year, so we've saved a great program to share with you this morning. My name is Troy McClellan. I'm your president and CEO, and we've got an exciting hour ahead of us this morning, so I hope you've got a good cup of coffee or whatever you're drinking this morning. You're settled in and are comfortable. Delray Medical Center is our sponsor. We once again have Dr. Ricotta as our guest speaker, so we're always excited to hear from him, who's already been in surgery this morning, just like he was last year when he spoke. And then, of course, we have the hospital's CEO, Maggie Gill, to give the sponsor spotlight. I want to just recognize Maggie and Team Delray Med for their continued support of our organization. Clearly, they are in the middle of this battle with the coronavirus, and they continue to do amazing things. So really, on behalf of the entire community, we say thank you to everyone at Delray Med, fighting it on the front lines, continuing to do it day in and day out. So we certainly appreciate that very much. And continuing to do this with us virtually. Like many of the other breakfast sponsors have, we very much appreciate your willingness to transition into this virtual world and be a part of this and bring what you do to our members and to our audience just in a different way. So thanks for that. But we got a great program. Let's get it started. I'm going to jump right in to Maggie's biography here. So Maggie Gill has served as the group CEO for Tenet Healthcare's Palm Beach Health Network and the CEO of Delray Medical Center since 2018. It's been 2 years already since Maggie's joined us. It's great, time's flying. The Palm Beach Health Network is the largest healthcare provider in Palm Beach County, consisting of 5 acute care hospitals, totaling 1,775 beds. Facilities include Delray Medical Center, Good Sam Medical Center, Palm Beach Gardens Medical Center, St. Mary's Medical Center, and the Palm Beach Children's Hospital, and of course, West Boca Medical Center. These hospitals provide a wide range of comprehensive services and have been consistently recognized by quality organizations such as Healthgrades, U.S. News and World Report, and the American Heart, American Stroke Association. Maggie is responsible for overseeing all strategic, operational, and clinical activities for the network. Before joining Tenet, Maggie served as the CEO for Novant Health UVA Health System, a joint venture partnership between Novant and the University of Virginia, located in Northern Virginia. Maggie provided strategic and administration oversight for the health system, including cultural integration, branding, and financial turnaround. Prior to her time in Virginia, she was with Memorial Health in Savannah, Georgia, where she served as the COO and then as president and CEO. As CEO, Maggie expanded the on-campus medical school and physician residency programs. She worked to grow regional clinical services, including trauma, specialized surgery, heart and vascular, oncology, women's services, and the Children's Hospital. She began her career with Tenet Healthcare, working as the CFO for hospitals in Miami-Dade, Florida, right here in our state. And she earned the Tenet Outstanding CFO of the Year award 3 times. Maggie has been named to Becker's Hospital Review 135 nonprofit hospital and health system CEOs to know, as well as one of 130 women hospital and health system leaders to know. She's definitely a person to know, and we're glad she's in our community. Maggie's a native Floridian, and she grew up just outside of Tallahassee, near our capital. She graduated from Florida State University with a bachelor's in English Lit. She received her master's in business administration from St. Leo, also in Florida, and completed executive education in strategic thinking at the Wharton School, University of Pennsylvania. Many other accolades that we can talk about for Maggie, but that short introduction certainly does provide you with the scope and depth of healthcare knowledge that Maggie brings to the table, and we are so lucky. My parents live very close to that facility. They've had to use it many times, and each time they've had fantastic care, and it's been a pleasure when we have to work with Maggie and any one of our team at Delray Med. So Maggie, thank you so much for doing this morning. To you and your team, thank you for what you're doing in this battle right now that we're in against this virus. And so pleased that you could share some time with us this morning and sponsor our breakfast. So with that, Maggie, I'm going to turn it over to you.
All right. Thank you, Troy. And thank you again, Troy, for that very gracious introduction and for sharing my life story. I appreciate that. On behalf of the entire leadership team for the Palm Beach Health Network, I want to thank everyone for attending today. We are all learning to adapt to a different world, and so doing things virtually has sort of become second nature these days, and really appreciate everyone tuning in to hear this presentation. We're honored to be the sponsor for the Boca Chamber Breakfast again this year. I'd like to extend my personal appreciation to Dr. Joseph Ricotta for taking the time to present a week in the life of a vascular surgeon during COVID-19. It's obviously a very timely and interesting topic. As Troy mentioned, the Palm Beach Health Network is the largest health system in Palm Beach County. And today we're going to focus on Delray Medical Center, the flagship of the county, and my home hospital. So I want to share with you some information about Delray Medical Center, not only about our quality and our safety awards, but a little bit about how we've been managing through this pandemic. Delray Medical Center, as everyone knows, has a long-standing reputation for quality care. We've been named to the America's 50 Best Hospitals for 15 years, and we pride ourselves on that commitment to patient safety. In fact, in the last 3 years, Health Grades has awarded us the National Patient Safety Award. And we've really taken that commitment to safety and applied it throughout this COVID-19 pandemic. We have created separate pathways in our hospitals for COVID and non-COVID patients, literally creating a hospital within a hospital to make sure that our staff and our patients stay safe. We're very fortunate that the positivity rates in the county and what we're seeing at the hospital continue to go down. We're probably at an all-time low than we were from the beginning of the pandemic. And as of a couple weeks ago, have started allowing more visitors into the hospital. So if you are admitted to any one of the Palm Beach hospitals, Delray Medical Center, you can have one visitor for your stay. So that's actually a pretty big step forward for us. We continue to have regular screening. We have rigor around testing. We have robust PPE and inventories to ensure that we have a pipeline of supplies to get us through not only this pandemic, but this upcoming flu season. And so we're ready. We have been safely providing care. We've kept our doors open, and we want the community to know that we are a safe place to receive your health care. So Delray Medical Center is in the top 1% of the nation, as you can see with the quality awards that were just on the previous slide. And I'll just list for you some of the 30 awards that we have been recognized with, including cardiac, orthopedics, neurosciences, pulmonology, GI, critical care, and GYN surgery. Most recently, we were recognized by U.S. News and World Reports as a high performer in the treatment of COPD and heart failure, two diseases that are very prevalent in our community. In addition, we were just recently named a comprehensive stroke center by DMV, and our surgical weight loss program was recognized as a center of excellence. So you can feel confident that the care that you are receiving in the Palm Beach Health Network and Delray Medical Center is the highest quality care that you can receive in the country, really. We are also dedicated at Delray to providing the most technological advancements. And so I'd like to share with you some of our most recent exciting medical breakthroughs happening at Delray. We're the first hospital in South Florida to perform a Precept PC deep brain stimulation procedure. So this technology is the first and only system with the ability to chronologically capture and record brain signals while delivering therapy to patients who have neurological disorders that are associated with Parkinson's disease, tremors, epilepsy, and other types of diseases like that. Dr. Lloyd Zucker, who is the chairman of the Department of Surgery and also our medical director for neurosurgery, completed his first case at Delray. Delray is also the first hospital in Palm Beach County to offer patients HeartLight X3 system for cardiac ablations. This procedure offers some of the most advanced treatments for patients with atrial fibrillation. This is a common heart rhythm disorder. Electrophysiologist Dr. Mark Freyer is the first physician to perform the procedure in our area using the system's miniaturized camera and advanced laser technology. Delray Medical Center is also using Navio orthopedic surgical system to help surgeons perform precise and accurate partial knee replacement surgeries. So we really do have an emphasis on robotics and minimally invasive surgery. And to that end have acquired another Da Vinci XI system that can be used in a wide variety of minimally invasive surgical procedures in the areas of GYN, bariatrics, urology, thoracic, cardiac, and general surgery. So we're committed to having the highest quality care, the latest technology in our hospitals, and we have doctors on the cutting edge. Delray Medical Center, as everyone knows, is a trauma center and one of the 2 trauma centers. The Palm Beach Health Network provides all the trauma care for Palm Beach County. That means that we have the highest level of physician expertise and training, enabling us to deal with the most complex cases in what's called the golden hour, so that you can get to our trauma center and you have the best chance of survival. Our emergency room and our freestanding emergency room are safe. As I mentioned, we have separate pathways for COVID and non-COVID patients. We still continue to see people in the community and around the country delaying care and coming in sicker. So we have taken the initiative of emphasizing that in an emergency, you should come to the hospital. It's safe, we can help you, and you should not delay care. So with the help of our partners at Delray Beach Fire Rescue, I'd like to take a moment to share a short video with you, highlighting the safe care at Delray, announcing our newly revised visitation policy that I just mentioned, and understanding because we understand the importance of having a loved one close to you when you have an emergency. And so with our advances in managing this pandemic, we want to be able to allow that and encourage people to come. So let's see the video now. Thank you.
Hello, I'm Dr. Dilip Ravi, an emergency room physician at Delray Medical Center, part of the Palm Beach Health Network. When you have an emergency, you deserve the highest quality care, and fast. At Delray Medical Center, you have access to a highly trained team that includes board-certified emergency physicians, dedicated nurses certified in advanced cardiac life support and pediatric advanced life support, experienced technicians, specialty surgeons, and consultants on call. Delray Medical Center is also a state-designated Level 1 trauma center, which means specialists are available 24/7. Delray Medical Center also operates a freestanding emergency room, the Emergency Center Lake Worth. There, you will find the same level of high-quality care and experienced staff available 24 hours a day. Delray Medical Center has been named one of America's 50 best hospitals and is a designated comprehensive stroke center. We offer the latest in minimally invasive, state-of-the-art cardiac, vascular, and endovascular care, neurosciences and neurosurgery, orthopedics, general surgery, robotics, oncology, rehabilitation, surgical weight loss, and behavioral health services. The emergency room at Delray Medical Center and our emergency center Lake Worth are open, safe, and ready to care for you. We have strict protocols in place to protect our patients, our physicians, and our staff. These include enhanced cleaning, limiting visitors and restricting hospital entrances, screening visitors and patients upon entry, separating COVID-19 patients in a closed unit away from other patients, wearing masks and other personal protective equipment to prevent unnecessary contact and/or spread of germs, frequent hand washing and hand sanitization stations located throughout the hospital, implementing a social distancing policy for patients and staff in all areas of the hospital, including the waiting rooms, installation of plexiglass protective shields in all registration areas, continually training staff regarding enhanced safety protocols. If you need care, please do not hesitate to call 911 and tell the paramedics to take me to Delray Medical Center. If you are admitted to Delray from the emergency room, you will be permitted to have one visitor stay in your room with you. We recognize the importance of having a loved one close by in times of uncertainty. Our patients and their speedy recovery are our top priority. No one plans to visit the ER, but when it happens, rest assured that the team at Delray Medical Center is here to keep you healthy and safe. We wish you a speedy recovery and thank you for choosing us for your healthcare needs. Delray Medical Center is part of the Palm Beach Health Network, one of the largest providers of healthcare in Palm Beach County. This integrated system includes 5 acute care hospitals, a dedicated children's hospital, freestanding emergency rooms, ambulatory care centers, urgent care facilities, and a host of outpatient imaging centers across Palm Beach County. All of our hospitals have received prestigious awards and accolades, national rankings, and multiple accreditations. For more information, visit delraymedicalcenter.com.
All right. And now the star of the show. It gives me great pleasure to be able to introduce Dr. Joseph Ricotta. We were lucky enough for him to join us in 2016, bringing with him a vision for endovascular surgery and robotics. He is Tenet's National Medical Director of Vascular Surgery and Endovascular Therapies. Under his leadership, our endovascular surgery program has grown exponentially. Our limb salvage and preservation program, which he talked about last year, involves a team with a wide range of experience and expertise, involving vascular surgeons, podiatrists, and wound care physicians, all focused on saving limbs and saving lives. The goal of our program is preventing amputation in patients with vascular disease by providing specialized interventions that spare tissue, repair damage, and help maintain and restore function in limbs that would otherwise have to be amputated. Dr. Ricotta and his team performed the first TCAR, transcarotid artery revascularization procedure on the east coast of Florida and in South Florida, May 31st, 2018. This is a cutting-edge technique to treat patients with carotid stenosis by minimally invasive approach as opposed to a carotid endarterectomy. To date, under the direction of Dr. Ricotta, Delray Medical Center has been named a TCAR Center of Excellence for 3 years in a row. At this time, I would like to share a video testimonial by one of Dr. Ricotta's patients, and then I'll share a little bit more about his background.
My name is Robert Fontanelli. I'm a snowbird. I had known other people that had strokes, and I thought I was having signs of strokes.
The ambulance brought us to Delray Center. He was having a stroke. They came in and they took him and said they were coming to Delray.
5 guys walked in the door. I couldn't believe. He says, "Who am I, the Pope?" I was eternally grateful that I came here because they said, "You have a choice." I said, "No, take me to the trauma center. Why would I go anyplace else?" They had TCAR surgery performed by Dr. Ricotta, and I feel great.
So Mr. Fontanelli is a very nice gentleman who had about a 95% blockage of his carotid artery. The risk of stroke was very high if we didn't do anything to treat it. At Delray Medical Center, we're one of 30 or so centers of excellence in the world that performs what we call TCAR, transcarotid artery revascularization. The advantage of TCAR over the traditional treatment, which is carotid endarterectomy, is that it provides better outcomes than carotid endarterectomy. The risk of stroke with carotid endarterectomy at 30 days is about 2%. With TCAR, it's less than 1%. And we found the results have been outstanding. The patients have quick surgeries, quick recovery times, and they're back to their normal life in 1 to 2 days. Vascular disease is not a disease that can usually wait. If you delay the care, the problem becomes more complicated, more complex. The fix is more complicated. Usually that results in a much longer hospital stay and worse outcomes.
I had no reservations at all about coming in here, COVID, because all the precautions are being taken. You'll be safe here, believe me.
You're more likely to get the virus at the grocery store than you are in the hospital. So if you're out shopping for lettuce and tomatoes, you can come to the hospital and have medical care. COVID patients are separated from the non-COVID patients, and basically they've created a very safe environment, not only for the patients, but also for the medical staff as well.
If we had gone home to New Jersey, we would fly back to come to Dr. Ricotta because there isn't anybody else that we would rather have.
I don't know if the people in South County realize what they have here, but this place is one of the best hospitals in the country, as far as I'm concerned. The results were what I expected. I didn't think there was an iota chance of anything being not the way it was supposed to be. I would extol the virtues of the staff, everybody. I'm very grateful for all the people that work at Delray Medical Center.
As you can see, Dr. Ricotta is a visionary. He is an exceptional surgeon, and he saves lives. Dr. Ricotta graduated from Yale University. He attended Jefferson Medical College and Medical School and performed his internship at Johns Hopkins School of Medicine. He completed his residency in general surgery and vascular surgery at Oxford University and his residency in general surgery at Johns Hopkins. Dr. Ricotta completed his fellowship in vascular and endovascular surgery at the Mayo Clinic and his fellowship in advanced endovascular surgery at the Cleveland Clinic. He is a diplomat of the American Board of General Surgery and a diplomat of the American Board of Vascular Surgery. As I mentioned, he serves as the National Medical Director of Vascular and Endovascular Therapy for Tenet. He's a professor of surgery and the program director of a vascular surgery fellowship with the FAU College of Medicine, hosted at Delray Medical Center. Please join me in welcoming Dr. Ricotta.
Well, good morning. Thank you for the introduction, Maggie, and I appreciate the opportunity to be with you all this morning. This is actually one time, although it's nice to gather in person, this is one time where I'm helped out by the virtual Zoom situation because I just scrubbed out of an emergency surgery. So it enabled me to quickly run down the hall to my office and get my computer set up and be able to be on time for this talk. So I thought, last year I spoke about robotics. Obviously, I didn't want to give the same talk as last year. I thought it might be interesting, given our current situation with COVID, to display some of the new techniques and technologies that we have in the vascular surgery world now, and some of the real focuses and services that we have at Delray Medical Center to demonstrate how do we take care of patients. So there was one day in late April or early May where I'm going to recount 4 cases that came in all on the same day to Delray Medical Center during the lockdown in the early days of the pandemic. That really demonstrate some of the new technologies and specific services that we offer patients at Delray. So I'm going to give you 4 case examples of patients that we had all on one day during the pandemic. As technology has advanced, the paradigm in vascular surgery, just as a background, has also advanced, and it's no longer about how big of an operation we can get a patient through. It's now about how we can fix a big complex problem with a small operation. So gone are pretty much the days where we have to make big incisions in patients to fix the problem. Now we can usually go through with a little puncture through the groin and fix things from the inside of the blood vessels with wires and catheters and balloons and stents, rather than from the outside through big incisions. We now have hybrid operating rooms. This is our $7 million operating room at Delray Medical Center that enables us to take care of patients with all of our tools. So open surgery if we need to make incisions, and the endovascular interventional procedures that are traditionally done in a radiology suite or in a cath lab. We now have the ability to do all of those procedures in one room in the surgical operating room, a one-stop shop, if you will. So patients don't have to come back on different days for certain types of procedures, and they don't have to be shuttled to different parts of the hospital. We can take care of everything in totality in this one hybrid endovascular operating room. I spoke last year, as I mentioned, about robotics. A lot of what we do at Delray Medical Center, just like in surgical robots with the Da Vinci, there is an endovascular robot that allows us to manipulate wires and catheters remotely from a console with buttons and knobs, and that gives us more precision and control of our instruments rather than human error or just manual manipulation. So we do a lot of endovascular robotics, and just to mention, we were the first in the United States in January of 2018 to do endovascular robotics in the country, and we've done more than anybody in the world. In terms of COVID and vascular disease, we know now that COVID-19 can infect and infiltrate the endothelial cells, which line, it's the first lining, the barrier of the inside layer of blood vessels, and they disrupt the barrier, allowing for infection of and inflammation of the endothelial cells, and this leads to creation of blood clots and blockages in the arteries and veins. And so many patients with COVID are now coming and presenting with strokes because they form clots in their carotid arteries or in their brains, blood clots in their legs, deep vein thrombosis or DVT, blood clots in their lungs, pulmonary embolisms or PE, and blood clots in their arteries in their legs that leads to ischemia, meaning no blood flow to the leg, and patients can have an amputation from that. And so those are the manifestations in terms of vascular disease from COVID. Vascular disease does not wait for lockdowns to end. So vascular disease can progress pretty rapidly. And so during this lockdown, we saw a lot of emergencies because patients didn't want to come into the hospital. They were afraid to come into the hospital, and they delayed their care until they couldn't delay it anymore. And it took a relatively simple procedure and made it into a complex procedure because the disease advanced pretty quickly. And so, delaying care can be life and limb threatening in terms of vascular disease. And I have a couple of cases that demonstrate that. So our first case is going to be actually Mr. Fontanelli, who was in that very nice video there, who had a stroke. And carotid artery disease, which is blockage and plaque buildup in the carotid arteries, can lead to a stroke. About a third of the strokes are from carotid artery blockages. And usually fragments from the plaque can break off and go up into the brain and plug up the arteries in the brain and cause a stroke. There's different ways to treat carotid blockage. Everybody gets medical management with medications to modify their risk factors like cholesterol and high blood pressure, etc. But interventionally, there's basically two ways to fix carotid blockage. You can do a surgical removal of the plaque called a carotid endarterectomy, or you can put a stent in a balloon inside the artery and open the artery that way. Traditionally, the stents were put in through the groin, where you would access the groin and you would have to put a wire and a catheter. I don't know if you all can see my mouse, but hopefully you can. You'd have to put a wire and a catheter through the aorta and then actually up through the carotid blockage before you can put a little basket here to protect any debris to go into the brain. And usually most strokes happen when you're manipulating where these black circles are, and you can, with the wire and the catheter, you can knock something off and it goes into the brain before you can even put the basket up, the protection system up. And then carotid endarterectomy, you make an incision in the neck, and you have to watch out for the nerves and other structures there, but you put a clamp on the artery and you prevent any, while you're doing the surgery, any blockage from going to the brain with a clamp. That's pretty much as secure as you can be. Most procedures are done by carotid endarterectomy, about 20% by stenting. But if you look at the data, the stroke rate is about twice as high with stenting than it is with surgery. The cranial nerve injury, and heart attack from surgery is a little bit higher than stenting, because stenting is a minimally invasive procedure, which is just a little puncture in the groin. TCAR, as Maggie mentioned, is now this new technology, and TCAR stands for transcarotid artery revascularization. And basically, it's the best of both worlds. It's the best of the stenting through the groin and the best of carotid endarterectomy. And this is just a little video that will show you, how we do it. We basically make a little incision, tiny little incision just above the collarbone in the neck. And then we access the carotid artery in the neck. So right away, we're avoiding the aorta. When you go through the groin, as I showed in that picture, you have to go through the aorta. We're avoiding that potential complication. We put a little sheath in the artery in the neck. And then what we do, this is the key, is that we clamp the artery and we suck the blood backwards. So we use what's called reversal of flow. So instead of the blood going up to the brain, the blood comes backwards and it gets filtered through a filter here, and it gets returned to the body through the femoral vein. And so by having the blood flow backwards, any debris that might come off during the procedure is sucked back through that sheath and filtered out and then returned to the body. So we can safely do a stent and a balloon, and any fragments that might break off don't go to the brain. They get sucked back into this sheath and filter mechanism while we're doing it. So that's how we protect the brain. Once we're done with the procedure, we take everything out, and then flow gets reversed back the right way towards the brain, and then we close the small little incision that we have. And so TCAR allows you to protect the brain much better than a stent through the groin. And it is a minimally invasive procedure, which only takes about 30 to 45 minutes. And so there's essentially no risk of nerve injury and no heart attack risk, which is what you have with carotid endarterectomy. So again, it's the best of both worlds. And if you look at the data with randomized controlled trials, as I said, it's about a 4% risk of 30-day stroke with a stent through the groin, about a 2% risk with a carotid endarterectomy, the surgery, and it's 1%, and now it's 0.8% for TCAR. So TCAR is really the way to go. We did the first TCAR in South Florida in 2018, as Maggie mentioned. We're one of 30 centers of excellence in the United States for TCAR since that time. And we've really built up our TCAR program pretty nicely. We've published a few papers. Again, these are from Delray Medical Center data and our fellowship with FAU. But we looked at TCAR in our patients over the age of 80. We had a 0% stroke death and heart attack rate. People stay for overnight and they go home the next day. And our flow reversal time, the average flow reversal time in the United States for TCAR is about 10 minutes. Ours is 4 minutes. And then we looked at TCAR and using some different types of blood thinners, namely Brilinta. And again, almost 70 patients. Procedure time average is about 45 minutes, and no stroke death, heart attack, and no bleeding events. So that's our own personal data that we just recently published. If we go to Mr. Fontanelli's case, the gentleman in the video, he came in with what's called crescendo TIA. So he kept having mini strokes after mini strokes. Every 30 to 60 minutes, he would have another stroke because, as you can see in the picture on the left, he has a string sign, we call it. It's about a 99% blockage in his carotid artery. There's very little blood flow getting through that. And the little bits of fragments of the plaque are going off into the brain and causing a stroke every time they go off. So this was during COVID. He came into the hospital and we did a TCAR procedure on him. It took 36 minutes. We had a 4-minute flow reversal time. You can see the picture on the right with the stent in, and there's a dramatic difference in the before and after pictures showing that we opened up that artery. There's his small incision just above his collarbone in the bottom corner. But very importantly, here's a picture of the filter. So that is all the debris that got sucked back with this reversal of flow into the filter. If we didn't have reversal of flow and they tried to do a stent through the groin, all of that would have got shoved up into the brain, and undoubtedly the patient would have had a massive stroke. And so TCAR allows us to safely treat these patients in a minimally invasive way with stents that has absolute cerebral protection of the brain with flow reversal. So that was our first case of the day on that Thursday morning with Mr. Fontanelli. The second case of the day is a patient that came in, a young patient, 45 years old, to the emergency department with shortness of breath and chest pain for about a day and a half. He didn't want to come to the ER, but ultimately it became unbearable and he came to the emergency room. He had a CAT scan and it showed a massive pulmonary embolism. And on this CAT scan, all the white is the contrast, and this is the right lung, and all that gray here is a huge goober of clot, basically, that's plugging the whole right lung. And you can see the left lung has some markings because the left lung is filling and it's alive. The right lung is blacked out. So the right lung is pretty much infarcted. There's no blood flow to that right lung. Interestingly, they did a COVID test because, he was having symptoms of chest pain and shortness of breath, and he was positive, but he had no symptoms of COVID at the time that we knew. So he had no fevers, no respiratory symptoms, no flu-like symptoms. His only manifestation of COVID and his first symptom was a pulmonary embolism. And this is before we really understood that COVID was affecting the blood vessels the way it did and making the blood vessels form clot. So this is, in my opinion, a pulmonary embolism that was caused by the COVID virus, the coronavirus. So he didn't do that well once he got to the operating room, to the emergency room. His oxygen saturations dropped into the mid 80s. His blood pressure dropped to 80. His heart rate went up to 120. We gave him a little oxygen that brought it up a little bit, but he was not looking well. So he was taken to the operating room emergently. Of course, we all donned our appropriate PPE, which, you know, we have plenty of, and took all the necessary precautions. And what we did is, instead of opening his chest and taking the clot out of his lung, which is, you know, traditionally how things would happen, which is a pretty morbid operation, quite honestly, we could fix everything through the groin with a little catheter, and this is called the penumbra thrombectomy device, and I'll just show a quick little video of how it works. But basically, you can just go in, again, instead of opening up the chest, we just can go in through the groin with a small puncture, and we can use this clot sucking system, basically, clot suction system essentially was what it is, that can break up the clot and remove it by aspirating the clot. And you can see on the bottom right-hand corner, there's a chamber that collects all the clot, and you can manipulate your catheter and wire up through the clot, break it up, and then use the catheter to remove all of the clot. So instead of having to do it with a big operation and a big incision, like I showed that picture of, we can do it with a small puncture. And again, instead of fixing it from the outside, we can fix it from the inside and just aspirate and suction that clot right out and restore blood flow. So here's his pulmonary angiogram, and that's the left lung. That looks perfect. His left lung is filling great. All that black there is the contrast. That's how the blood fills. Left lung looks great. The right lung has no blood flow. So the right lung is basically dead or dying at the moment because there's no blood flow getting to it. So we were able to go through the groin, go up through the heart, and into the lung, into the pulmonary artery, into the right lung, and suction all the clot out. And now you can see the contrast is filling, and the lung now has blood flow. And there's sort of the before and after picture. And that on the right-hand side is all the clot that we removed from that patient's right lung. So we restored blood flow in a matter of about 3 to 4 minutes, just through a little puncture in the groin of his right lung. Normally, if you had to do a thoracotomy and open up the chest, you know, it takes at least 30 minutes probably to get into it. So this is 3 to 4 minutes. We're able to restore the blood flow to the lung immediately. And this is really a testament to what we call the PERT team at Delray Medical Center, the Pulmonary Embolism Response Team. It's one of few PERT teams in the whole state of Florida. And it's a compilation of multiple service lines and disciplines, including the emergency department, the ICU, radiology, cardiology, vascular surgery, all coordinated care for patients with pulmonary embolism. And we have strict protocols when people come in with pulmonary embolism that we follow. And having a structured organizational process like this allowed this patient to be in the operating room from presentation in the emergency room in a matter of minutes. And as I said, you know, 2 to 3 to 4 minutes later, he had blood flow back to the lung. If we didn't have this team, it would have taken much longer. So, you know, we developed this team about 1.5 years or 2 years ago at Delray Medical Center, and we've really done a great job taking care of patients with pulmonary embolisms. The third patient of this day was an 84-year-old patient who came in with a ruptured complex aortic aneurysm. So, you know, we didn't have any elective surgeries during this time because we were going through the lockdown. And, you know, we got up that morning probably thinking that we didn't really have that much to do. But as you can see, today turned into a relatively busy day. So this patient presented to the ER with abdominal and back pain for 2 days. Again, didn't come to the hospital because he was afraid of the virus, and tried to stick it out and wait it out as long as possible, but the pain became unbearable and had to come in. They got a CAT scan, and this patient had a ruptured aortic aneurysm. So he was sitting at home for 2 days with a ruptured aortic aneurysm because he was afraid to come into the hospital. The mortality of a ruptured aortic aneurysm, if it's left untreated, is 100%. So 100% of the patients will die if we don't fix that. Even if you try to fix the aneurysm and you take them to surgery, it's up to 60% mortality. So it's a very high risk procedure. In an 84-year-old, the mortality is probably 80 to 85%. Traditionally, these are fixed. This is just a CAT scan showing his rupture again. Traditionally, these are fixed with opening up the belly through a big incision and trying to find the aneurysm and seal the hole and then sew a new aorta, take it out and sew a new graft in. But again, with the new endovascular techniques that we have at our disposal at Delray Medical Center, we're able to fix things from the inside. So no incisions, just a little puncture in the groin. This is just the CAT scans, this special software that we use to see the aneurysm. As you can see, it's a big ruptured aneurysm right here, and we can plan how we're going to make a graft, because I have to actually construct this graft for this patient. I can't use a commercially available graft because it involves the kidney arteries and the intestinal arteries, and it's a little bit more complicated than that. So I had to make specific measurements to the 1/10 of a millimeter as according to the patient's anatomy, so that I could custom make the graft. And then on the back table in the operating room, while the patient is being prepped by anesthesia in the background there, I'm with the fellow making the graft and basically taking a commercially available graft and modifying it, creating holes for the kidney arteries and for the intestinal arteries. And what I'm going to do is put this tube into the patient's aorta and then line those holes up with those arteries and then put stents out into those holes, those fenestrations, to preserve blood flow to the kidneys and the intestines, because you can't just put a stent in the aorta and cover them, because the patient, that's incompatible with life. They need blood flow to their organs. At Delray Medical Center, I have a physician-sponsored IDE from the FDA to custom make these grafts. So we make them ourselves real time to treat emergencies such as this. So here's the picture of the aneurysm. I think it's probably obvious to everybody that it's this big thing that is pushing out to the patient's right side. This is just an intraoperative photo showing those fenestrations, those circles, those holes that we made in the graft, and lining them up with the kidneys and the intestines. And then through those holes, we put other stents in. So these are stents within stents within stents. And there's the final picture showing that this aneurysm is sealed and that there's blood flow to the kidneys, there's blood flow to the intestines through these stents. And there's the before and after. So this patient came in, again, it's about an 80–85% mortality for somebody of his age. All comers, it's a 60% mortality. It took about 3 hours to do this procedure. The patient was extubated in the recovery room, didn't receive any blood transfusions, and actually went home on the 3rd hospital day. Anybody maybe that has had any experience with ruptured aneurysms, usually these patients are in the ICU. If they live through the surgery, about 50% of patients with a ruptured aneurysm get to the hospital alive, and of those 50%, about 50% of them make it through the surgery. So if they live through the operation, they're usually on ventilators in the ICU for prolonged periods of times. They usually have days to weeks in the hospital, and usually go to some kind of nursing facility, not discharged home. This person, because we were able to fix the aneurysm, the ruptured aneurysm, from the inside through just a small puncture in the groin, this patient was able to go home on postoperative day 3. The following day after the surgery, instead of being hooked up to the ventilator and a lot of tubes and things, he was eating Jell-O for breakfast. So this guy, the day before, came in with a ruptured complex aneurysm, and the next day, that's what he looked like. So that's just a testament to the technology that we have at our disposal and the advancements that we've made in vascular surgery to be able to treat these patients. So that was our 3rd case of the day. And I'm going to do our last case of the day as the end of the talk here. So peripheral artery disease, as many of you know, is a blockage, a buildup of blockage in the arteries that go to the legs, and it's poor circulation into the legs. It affects up to about 12 million people in the United States, and it's a spectrum. On the early side of this end of the spectrum, it's patients who maybe have some pain in their thighs or calves when they walk, and then the pain gets worse and they can walk fewer and fewer, less distance before getting the pain, or they get pain at rest. And on the other end of the spectrum, it's patients that have, sores, non-healing wounds, gangrene, and that's what's called critical limb ischemia. And those are the patients who are at high risk for amputation. There's over 650,000 amputations done every year due to critical limb ischemia in the United States. And unfortunately, more than 50% of these patients don't have an angiogram to look at their blood flow and don't have a procedure to optimize their blood flow prior to the amputation. So nobody even tries in over 50% of the cases to improve the blood flow and optimize it. Maybe the amputation can be prevented, or it's a lower level of amputation. So at Delray Medical Center, we're very aggressive about this, and I'll talk about the limb salvage program in a minute. Just quickly, in terms of the healthcare economics, the annual spend per Medicare patient is about $200 billion annually on patients with PAD. And the biggest drivers of healthcare costs are readmission of the patients and amputations. In terms of readmissions, wound status is the highest influencer, the biggest influencer on readmission. So patients that have a wound that heals are less likely to get readmitted. That makes sense. And patients that have wounds that don't heal and persist are going to come back and keep coming back. And so to prevent readmission, we want to try to heal that wound, and also to prevent amputation, as I'll show you. So in terms of amputation, again, the cost to the healthcare system in 2015 is about $25 billion. So readmission and amputation are the biggest cost drivers. Again, amputation is significantly affected by non-healing wounds. If you can heal the wound, the patients usually don't end up with an amputation. If you cannot heal the wound, they end up with an amputation. And bigger than the economic impact of that is the patient outcome impact of that. So unfortunately, there's an extraordinarily high mortality associated with amputation. At 1 year, if you do an amputation below the knee, and you can save the knee joint, you can see what a dramatic increase it has versus an above the knee. But still, at 1 year, 25% of people with a below knee amputation will die, and about 50% of people with an above knee amputation will die. At 5 years, those numbers even go higher. It's about 75% of people with an above knee amputation will die in 5 years, and about 65% with a below knee amputation. So we don't want anybody to have an amputation, because the mortality skyrockets once that happens. We try as hard as we can, if they have to have an amputation and they're unsalvageable, to at least save the knee joint and do a below knee amputation, because the mortality is less and they can be fitted with a prosthesis and have some sort of quality of life. Sorry for some of these gross pictures. Hopefully you guys aren't having breakfast right now, but again, gone are the days where we have to make a big incision in the leg to fix problems. We can do a little puncture and fix everything from the inside. This is a very interesting study that looked at sort of the turn of the century and how people addressed peripheral artery disease. And at 1999, 100% of these procedures were done with bypass surgery. So big cut in the leg, open surgery, doing a bypass from above the blockage to below the blockage. The amputation rate was 32%. Over the next 10 years, endovascular technology really evolved and took off, and most of these procedures were done endovascularly, 90% or so, and the amputation rate, I don't know if you can see it on the slide, but is about 5%. Nowadays, at least in our practice, it's probably about 95% endovascular, so just through a puncture in the groin and fixing it from the inside, and about 5% surgical, and we'll go over our amputation rates in a minute. But the importance of this slide is, as people had more endovascular procedures, the amputation rate went down. And the reason for that is because when you go with wires and catheters through blood vessels, you can get into more smaller arteries and smaller vessels than you could ever sew a bypass to. So we can fix these 1 millimeter arteries with balloons and things like that. You can never sew a bypass to a 1 millimeter artery. So endovascular technology allows us to go further and further into the vascular tree. You can even go into the artery to the toe and open that up, where you could never do a bypass to that artery. So it allows us to have better outcomes. So here's our fourth case of the day. Again, sorry for the disgusting photo, but I hope it makes my point. So there's another patient, unfortunately, that delayed seeking care until this wound in this dorsum of the foot got so bad that the tendons of the foot were showing. Whoever saw this patient told them that they needed an amputation right away. It does look pretty bad. And again, it goes back to, delaying care and making something that is relatively simple to fix much more complicated to fix with a much higher risk. So here's this guy's leg. On the picture on the left, there's no blood flow missing in the superficial femoral artery. This is the thigh. Here's the knee right here at the bottom of the picture, and there's no blood flow going across the knee, the popliteal artery. This is the leg, and there's essentially no named blood vessels in the leg. And here's the foot. There's no blood vessel into the foot. So there's no, even if you wanted to do a bypass surgery, there's no artery to do a bypass to because there's no blood flow into the foot at this point. Again, we can use robotics for these procedures. They're very helpful in terms of improving our precision and control of the wires and the catheters. And we can use robotics. So here's the before and after picture showing that we opened up that blockage in the artery and cleaned it out and ballooned and stented it. There's the before and after picture across the knee. There's the before and after picture in the leg, as you can see, and even into the foot. And we were able to restore the blood flow into this patient's foot. And then with the help of some wound care and applying a skin substitute like a graft on the patient's wound, we were able to heal that patient's wound. And this patient ended up doing fine and not having an amputation. So unfortunately, it was a little bit more complicated than it needed to be, and it would have been better for them to come to the hospital a little bit earlier. But still, using the technologies that we have at our disposal, we're able to save this patient's leg. I'm almost done. Briefly, I want to talk about the Delray Medical Center limb salvage program. So one of the things that we've really focused on is amputation prevention and limb salvage. And just like this patient I showed you, this is a result of a multidisciplinary approach to the patient. So a limb salvage program basically coordinates care for the patient that has wounds. And that's going to involve a wound care specialist, usually a podiatrist, the primary care doctors, endocrinologist or nutritionist, because most of these patients have diabetes, nephrology, some of them have kidney disease, plastic surgery for maybe skin grafts or wound care, infectious disease because a lot of the wounds are infected, and then vascular surgery to improve the blood flow. Most of these patients, unfortunately, operate in silos. And so they go and see these different specialists, but there's not great communication between the specialists. There's not a coordinated network to take care of these patients. And so the limb salvage program that we've built basically eliminates these silos. It puts the patient at the center, and then all the healthcare providers that are taking care of the patients are connected, and we're able to deliver much better and more efficient care to the patient. And as I'll show in a couple of slides, really make a significant impact on amputation prevention and limb salvage. There is some data to support these limb salvage programs. This is out of Tennessee, and basically with a coordinated effort, as I described, this group had decreased their number of amputations, which is in red, decreased their percentage of amputations, the green line, all while taking care of more wounds. And that's because they had coordinated care. They were aggressive about restoring the blood flow. They were aggressive about wound care. Nobody got an amputation without an angiogram or an attempt to optimize the blood flow. And what they also demonstrated was that their time to wound healing, again, healing the wound prevents amputations and prevents readmission to the hospital. They decreased by 50%, from 51 days to 25 days, the time it takes to heal a wound by this aggressive multidisciplinary approach. Our limb salvage program at Delray Medical Center, I got here at the end of 2016, so actually 4 years, I think, maybe today. We've decreased our amputations by over 80% in almost 1,600 limb salvage cases. Again, using this multidisciplinary approach, coordinated care for the patients. Our number of amputations have gone way down despite the fact that our number of vascular procedures have increased exponentially. So in 2016, our amputation rate was almost 17% at Delray, and now it's 0.7%. And this is, again, because of this coordinated care with the limb salvage program. We've also decreased our readmissions to the hospital by 75% during this time. So in terms of critical limb ischemia, it's vital to improve blood flow into the leg, and that saying of save a leg, save a life is really true, as I've demonstrated. So that's the end of my presentation of my very fun day a few months ago during the COVID pandemic. 4 challenging cases that hopefully demonstrate some of the new vascular technologies that we have at Delray Medical Center, some of our programs, and most importantly, the message is don't delay your care. If you have an issue, as I said in that video, come to the hospital. It's safe, probably the safest place you can be, quite honestly, and we can take care of things before they become more complicated. So thank you very much for your attention and your time this morning. I appreciate the opportunity to be with you.
Well, Dr. Ricotta, thank you again. I'm sitting here absolutely captivated by everything you're saying, and just amazed by the new technology and techniques that you have created and what you're doing every day. And that was one hell of a day, it sounds like, in the life of Dr. Ricotta. So I think it gave us amazing perspective on what you're doing amidst this virus situation. And wow, thank you. That's just amazing stuff. And happy 4-year anniversary at Delray Med. I heard you say that. So thanks for sharing your time with us on your anniversary, and those patients, including Mr. Fontanelli. Sure, we're lucky to have you when they went to Delray Med. You know, there, and you just reiterated at the end, but clearly consistent message is don't delay your care. It's there, you're all there to do that. And we certainly want to reiterate that to everybody, certainly who's on the call. We're kind of right on time right now, but I just want to ask you one question, and I think it's great given what we just saw from someone in the audience, and that is, you know, knowing that, I mean, you've got these unbelievable procedures and technology to save and heal people like you just demonstrated. But what can people do to not get to that point? I thought that was an interesting question. We know you probably don't want patients to get to that point. You can fix them, but we'd rather not have them get to that point. What would be, you know, one thing that you could say to this person or people, just say, how do we not get there where we rely on, you know, your expertise to fix us?
Yeah, that's a very good question. So, you know, a lot of what we do in vascular surgery is actually vascular medicine. So, you know, one of the reasons why I went into vascular surgery, besides the technical challenges of the procedures, was because I actually get to be a doctor. A lot of the surgical specialties are more procedural based, and you don't really get to take care of patients, and these patients are usually pretty sick. And so we practice a lot of preventative medicine and vascular medicine, and I enjoy, you know, practicing the art of medicine, so to speak. And so obviously we try not to have patients get to that point, and it's really centers around managing risk factors. And the 4 major risk factors for any vascular disease are diabetes, smoking, high blood pressure, hypertension, and hypercholesterol, high cholesterol levels. And then genetics plays some role in it, and you can't do anything about your genetics. But so 90% of my patients either smoke or have smoked at some point, and it only takes about 100 cigarettes to start the damage. So if you smoked for a couple years, 30 years ago, it's great that you stopped smoking, but you still did some damage to your vessels that will continue to progress over time. And so getting people to stop smoking is key, and then managing, you know, their glucose if they're diabetics, and their blood pressure and their cholesterols. Those are the important things. So it's all about the risk factor modification, essentially. And then if the disease progresses despite risk factor modification, then, you know, fortunately there's things that we can do to fix it. But the answer to your question is that we start very early on preventative measures. Now, usually a lot of times when patients get to me, they're already sort of beyond the point of reversing those things. And so I would encourage, you know, the primary care doctors and other healthcare providers that if people are on the early stages of some vascular issue, we'd rather see the patients earlier so that we can try to adjust everything and then just survey them so that the disease, we can slow the disease progression as much as we can.
Wow. Great answer, and I appreciate you going through that. Obviously, preventative is the way to go. But I know your phone's going off. I know you're busy. You came from a surgery before you even got on this morning. Thank you. You're probably going to be called away shortly. So I'll stop that with the questions and move on. I just want to make a couple of announcements. Coming up, we've got a couple more virtual events before people have to hop off. One is coming up on October 23rd, sorry, we have our big business awards luncheon, and I sent out an announcement via email about our recipients. The small business leader is Anik Khalid with Maggiano's. The business of the year is Therapeutics MD, and then our business leader of the year is Pastor Bill Mitchell at Boca Community Church. So we hope you're going to join us for that. And we are going to have our holiday auction again this year. It's going to be virtual. That's going to be on December 2nd. So with that, again, I want to thank Dr. Ricotta. I want to thank Maggie Gill and the team at Delray Med for supporting us, for doing all the great things that you're doing in our community. So like with everything else at our breakfast, we're going to have the door prize, which, by the way, donated by Delray Med, is an iPad mini. So Chastity's going to spin the wheel, and we are going to see who gets the iPad mini. This is the greatest thing in the virtual world. Greg Plakas, you win. You can work with Chastity. We'll make sure we get you your iPad mini. Again, thanks, Maggie, Delray Med, Dr. Ricotta. Everybody have a great day, a healthy day, and a safe day, and we'll see you real soon on the next Zoom. Take care, everybody. Thank you so much.